So, Dr. Girdhar.
Yes. So good evening, all. I am Dr. Girdhar, and I am chairing this session. I thank the AIOS and Namrata Sharma for giving me this opportunity to be among some of the doyens of vitreoretinal surgery in India and some very accomplished international faculty. With me as co-chairman is Dr. Lalit Verma. He needs no introduction. He is, I would say, the torch bearer of the All India Ophthalmological Society and Indian ophthalmology for probably more than a decade now. He's a former professor from the RP Center, All India Institute of Medical Sciences, and presently a very senior vitreoretinal surgeon in Delhi, associated with the Center for Sight. The convener is my colleague here in Cochin, Kerala, Dr. Gopal Pillai, again very young, very dynamic, and already a very accomplished vitreoretinal surgeon. And he is a professor of ophthalmology and vitreoretinal diseases at the Amrita Institute of Medical Sciences, Cochin. And the co-convener is Dr. Partha Rana. Dr. Jai Chablani will be moderating this session, and I hand over the proceedings to Dr. Jai Chablani, who was one among us for a very long period of time, and I was always thinking that he will contribute a lot to Indian ophthalmology, but he has decided to contribute more to global ophthalmology. So he is now in the University of Pittsburgh, USA. Over to Jai.
Thank you so much. Thanks a lot. And I think it's really a great honor to organize this symposium. And I'm very much part of Indian ophthalmology and global ophthalmology. I'm just going to share my slides and introduce the speakers. So the plan is that we will have case discussions, and each case will be presented for 4 to 5 minutes, and then we'll have 6 to 7 minutes of discussion. And we will try to answer the audience questions through the chat. But if there is time remaining, we can definitely bring it to the dais, and we can take opinions from the experts available here. All right, so I'll start with Sunir. Sunir is a very good friend from Wells Eye Center. I'm not going to talk about each, because I started preparing the slides and I realized that it's getting too crowded with everybody's achievements. So I decided just to cut it short, and I'm sure everybody is aware of many of them. Sunir is from Retina Service at Wells Eye Hospital in Philadelphia. Then we have Alexandra, a very good friend from Kola Institute, Cleveland. Yoshi also works at Wills Eye Hospital, is particularly interested in pediatric retina. So we definitely need this flavor in our symposium. Daras from Shroff Eye Center. And we have Dr. Murthy from Retina Institute of Karnataka, Bangalore. I'm sure we have learned a lot from his fantastic surgeries for last few decades. Rajanarayanan from LV Prasad, he is very well known for his macular surgeries. And then Vinod, a very active clinician, a fantastic observant for medical retina cases, but I wanted to get his expertise in surgical retina as well. And Dr. Pramod Bhinde, my guru from Shankar Netralaya, I cannot thank him enough for making me what we are today. And Anirudh, a very good friend from PGI Chandigarh, an upcoming star from India. So I apologize to all of you that I really could not bring too much details about each of you. But let's start with Sunir's case, and let's get the ball rolling. Thank you. Sunir, go ahead, please.
Thank you, Jay, for inviting me to this great symposium. And this is a case of a glass-blowing intraocular foreign body. This is a 25-year-old person who was a professional glass blower who developed a foreign body sensation in floaters while glass blowing. He was wearing safety glasses, so it wasn't exactly clear the mechanism of the injury. When he came in, the vision was 20/20 in each eye. He had no APD. The pressures were normal. And in the left eye, he had a conjunctival hemorrhage, some mild conjunctival chemosis. The cornea and anterior segment were otherwise unremarkable. This is a photograph of the right eye, which looked great. And in the left eye, you can see an area of hemorrhage suprarenasally that's sort of linear in its shape. But otherwise, the retina looks pretty good. And when you focus in on this area, you can see what looks very much like a puncture site. And then when we're doing extended ophthalmoscopy, in addition to the hemorrhage, you can actually see a piece of glass that was impaled in his eye. So it went in approximately through the pars plana and then impaled itself into the retina, probably through the sclera, where a piece of it broke off and was just sort of stuck inside the eye. We then got a CT scan, and you can see one piece, but there's a sense that there's multiple fragments of glass in his eye, not just the one that was visible on extended ophthalmoscopy. And so we took him to the operating room. Here's his main entry site. It's about 5 millimeters posterior to the limbus. And when we went in surgically, he was young, so we had to induce a PVD. You'll see that there's this piece of glass here, but then there's multiple smaller pieces of glass. What we think happened was he had a fairly long, maybe 3-4 centimeter thin piece of glass that went into the eye. And once it impaled in the back of the eye, it started to break off into multiple smaller fragments, which were then lying on top of the retina. Well, we lifted the hyaloid up, which I think is an important thing to remember in these cases. And here's, you can see his original entry site. We then enlarged the primary wound. And then we started removing the pieces of glass. Removing these pieces of glass was quite tough, partly because the forceps weren't really wide and they were long and tubular. So it was difficult to get a good purchase on them, but eventually we were able to remove them. One thing that we found to be very helpful is to make your sclerotomy somewhat larger than you would think necessary. We lasered the brakes, and then of course we put in oil tamponade in this individual for a total oil fill. And then the next day, a week later, he looked pretty good. There was a small little bit of retained perfluorocarbon liquid pre-retinally, but the macula looked good. All the laser areas were well treated, but 2 months later, he developed bad PVR, and then with several additional surgeries, he ended up remaining attached without oil, but the vision had deteriorated to count fingers.
Excellent. Very nice. Dr. Giridhar, do you have any comments on this case?
Yeah, I mean, very nice presentation, actually. When I saw this, the title as Glass, I was reminded of a similar case which we operated here about 20 years ago with multiple glass pieces in the eye. And what I wanted to ask Samir is, what's the instrument you use to remove the glass piece? I mean, because standard IOFB forceps, usually it's very difficult to get a grip on the foreign body. It just slips. And second thing is the edges are very sharp. So getting it through a sclerotomy, even after enlarging, is not at all easy to get the glass foreign body out. Because in that particular case, of course, the size of the foreign body was multiple foreign bodies, some of them very large. Finally, we removed the lens and removed the glass through the anterior segment. That is, we brought it to the anterior chamber, and then we removed it through the anterior segment, because we found that removing it through the pars plana was very difficult. So I just wanted to ask you, what's the instrument you use? What were the intraoperative difficulties? Because since you PVR, that means you had a lot of surgical difficulties in removing the foreign body, most probably. That's the reason why probably there was so much of PVR, and the final visual outcome was quite poor.
He had multiple puncture sites when we were intraoperative. And whenever you have hemorrhage and then liberated RPE, obviously the incidence of PVR is going to go up a fair bit. But removing the glass is very tough, simply because the grass in this case was round, and you're trying to grab something smooth with forceps, so it kept on wanting to pop out. Luckily, we just used good old-fashioned 20-gauge serrated forceps, and the pieces were small enough that we were able to grab them on the long end and withdraw them. But some things that we had talked about using were to put in a chandelier for a bimanual technique to sort of change the orientation of the glass. Ideally, you would have something that would be rubberized. If you had rubberized forceps, that would be helpful. I've seen other people that have used something like a finesse loop, which is a retractable loop, which people use sort of like they would a Tano scraper. And then you could use that to lasso some of the pieces, tighten the loop up and withdraw it from the eye that way. That's another option that was available. But glass in these cases can be really tough to remove.
Right. I think the good part is that the retina was attached in the beginning, so you did not face challenge, because when I saw your video, it just reminded me of one of my patient who came with large glass foreign body with the sharp edges with detachment. So that gets really difficult because the glass edges are really sharp, and deal with the detachment and taking it out was a nightmare. Excellent. Gopal, do you have any comments?
Yeah, glass is actually very, very complex because the shape of the glass itself is sometimes very difficult. So either it could be a globular, larger glass particle with multiple sharp edges. Even if, like Giridhar said, if you are taking it through the cornea, you may have to actually enlarge the opening significantly, because otherwise it will completely damage the corneal, the tunnel through which we are operating, removing it. And
Right.
as Sunil was telling, it's extremely difficult to hold that with forceps. So some people have used diamond dusted forceps. Some people have used snares. I think there is a renal calculus remover, something which is there, which is another instrument in which there is either a lasso or something like a basket-like thing into which you could hold the glass piece and then take it out. These are some of the atraumatic ways of removing the glass. Another important problem is whenever we are trying to remove the glass, it may break in our hands. So during the removal itself, it could break multiple times, and maybe it will lodge in the pars plana, which is even more difficult to remove at that point of time. So getting that out, and once you have this multiple pieces inside and when you are taking out, I think the vitrectomy needs to be really very thorough.
Right. Anybody else has any quick comments? We still have a few minutes.
Can I show one of my videos where we dealt the glass foreign body?
How many minutes do you have?
Just a minute.
Sure, definitely. Go ahead, Vinod. It's always fun
You'll have to
see.
share unshare, Sunil.
Lalit has asked a good question. I mean,
I was till the time he puts up Vinod, because in India the patient reaction, you see 6 to finger counting, he will blow you out.
Okay. Yeah, Sunil, he means the patient's reaction towards the count finger, not PVR reaction, which is sometimes more scary.
Yeah, I mean, these are tough conversations. I mean, when you see it, he was a glass blower. He was looking up at one of his objects, and then a piece broke off. And it's always tough when a patient comes in with, good vision, just a little bit of haziness and some irritation. Sometimes it's important for us to explain to them how concerned we are for their future, not with what's happening right now, and how the body's own healing mechanism can sometimes work against them. So, that preoperative conversation is hard, but I think it's critically important to help frame what we anticipate happening over the next few months or a year.
Right. Vinod, go ahead. Let's see what you got.
So this was a young guy who had come to us with the repaired corneal puff elsewhere with the cataract. He had injury with a basically ruptured bulb. So a glass piece went inside. So once we managed the lens, so this is what we found. There's a large glass piece, and it has already punctured the papillomacular bundle. So I tried to lift it with edges, but could not hold it. But finally, I used the light pipe to slide beneath it, and then 20 gauge serrated forceps to hold it. So once it was there in the grip, it was easy to remove through a corneal wound. But just to, again, the point has been well highlighted that the edges are sharp and it is really difficult to hold it. So
I think that putting a chandelier and handling it bimanually was a very important suggestion, because that is something which avoids the edges and avoid damaging the retina around. So that helps. All
EFCL in
right.
these cases, do you think that they
One
will
point to
actually?
add here, sorry, the during diagnosis ultrasonography, because very typical features you get, like because of multiple reflecting surfaces, lot of your, sometime you can erroneously diagnose as a multiple foreign bodies rather than one single foreign body. That also you need to keep in mind.
Yeah, that is true.
Yeah, Jay, so
EFCL does not erase the glass particle many a time, most of the times.
I think
Just-
Yeah. Raja, you wanted?
just a brief point. One of my patients is a medical student driving, and he crashed his BMW. The glass windshield broke into multiple pieces, and some of us can be lucky the way Vinod showed. At least he could grasp it. Some of them are so irregular and huge, you just cannot do anything. I had to use a vectis and make a large corneal incision and float it up, and ultimately after that use a vectis to pull it out. So all these cases are extremely challenging. You really have to be innovative when you take care of them.
Absolutely, absolutely. All right, let's move on to Alexandra. She has something interesting to show us.
All right, let me pull up my presentation. Give me 1 second.
Just to add up, I believe the audience will be writing on Q&A, so I request you all to just keep that open and keep responding if you see any questions. Thank you. Yeah, go
All
ahead.
right, can everybody hear me okay?
Perfect.
All right, so this starts as a medical case, and we'll know that it's going to go into surgery since it's a surgical panel. So this is an 82-year-old gentleman. I'm following his other eye for retinal vein occlusion, and this is his good eye. And he's 20/25. You can see he has a little bit of ERM and lamellar hole, but otherwise he's doing really well. And this is the image from his visit. And once again, we're getting it because we're following the other eye, but you can see that he has some retinal hemorrhages along the superior arcade. He has some peripheral drusen and a nevus, and along the inferior arcade in the macula, he has some retinal hemorrhage. So here's the fluorescein angiography, wide field fluorescein angiography of this patient, and you can see that he has multiple retinal macroaneurysms. So maybe I can pause here for 1 second and just ask the panel, 20/25 asymptomatic, would anybody do anything with these RAMs other than sending him to his primary care doctor and tell him to get his blood pressure under control?
Yeah. Nothing else.
Nothing else. Okay. So we're in agreement.
Yeah, but I would not send him to his PCP, but I would say you come back, you can burst anytime.
So so we know that there's more to this story, right? So I decided to watch him just like everybody else. And he comes back now a couple months after the FA, he's 21/50. And you can see, I don't have the image color photo, but on OCT, he has this new subretinal, intraretinal fluid. And you can see on ANFAS that there's hemorrhage. So it looks like he either developed a retinal vein occlusion or his RAM converted to a hemorrhagic RAM. So what would people do at this point, 21/50?
Nobody.
Inject?
Inject? Okay. So I agree, and we injected bevacizumab, and I told him, come see me in a month. He comes back in about a month and a half, and he's count fingers now. So I'm not feeling so good, and I can't see in the back because he has dense vitreous hemorrhage. And on the ultrasound, he is found to have a retinal detachment from 730 to 3, so inferior. And in the macula, he has a subretinal hemorrhage that is measured on the ultrasound to be about 2.9 millimeters. So would anybody like to comment what they think happened and what would they do at this point?
Was the
Raja?
patient on ecosprin, globulate, or VARF?
I'm sorry, I couldn't hear.
Was the patient on ecosprin, globulate, or one of the anticoagulants?
No, he is not anticoagulated. Great question.
Yeah, I would like to take him up for surgery, but Alexandra, the previous visit when you showed the OCT, I believe initially the angiogram showed more than one RAM, correct? So
Correct.
were you also observing the other RAMs? Were you thinking of lasering the other ramps, before they also kind of burst and cause bleeding? I don't know which one would have burst, but at this point of time, definitely surgery, and looking at the amount of subretinal hemorrhage, we are looking at probably even TPA at this point of time.
Yeah, I think it's a great point. I thought that it was the one that was most proximal to the nerve, just given the location of the hemorrhage that was misbehaving. And I was pretty confident giving him anti-VEGF, and I thought that it would tie things over. And it's interesting, and I don't know if of any literature where you have multiple RAMs, and what is, if one starts becoming hemorrhagic, what is the likelihood that the other ones are gonna progress along the same lines. But I agree here. I think, when I look at this picture, obviously I'm concerned that he has more hemorrhage from RAM, but at the same time, we just gave him an injection, and with retinal detachment, I'm worried maybe there's a rhegmatogenous component as well, although that's less likely on my differential. So we decided to go in, and here's the surgery, and you can see there's dense vitreous hemorrhage. We are clearing it out. And as we clear it out, we can see that there is significant submacular hemorrhage. And peripherally, he has this large, what appears to be serous retinal detachment. We didn't find any breaks, with pretty extensive subretinal hemorrhage.
Wow.
So at this point, and maybe I can just pause for 1 second, somebody mentioned TPA. Would you still consider doing TPA, and where would you put it in? What's your kind of approach when you're thinking of using subretinal TPA, or was it intravitreal TPA?
So in this case, as you can see, most of the hemorrhage is localized to the posterior pole. Some of the cases have extensive subretinal hemorrhage, including under the retinal detachment, where you may have to kind of do an evacuation, waiting for the TPA to act for about 20 to 30 minutes during the surgery, and then do a complete evacuation. But over here, since it's just localized, at least the hemorrhage localized to the posterior pole, you may want to just inject subretinally and just put in gas and see how it displaces post-operatively. I would not do the earlier version which I was mentioning of having to wait for half an hour for the blood to liquefy completely. Over here, just a simple subretinal injection, maybe around the infratemporal area, a couple of spots, a couple of points you may want to inject, and then just put gas inside this eye. I'm making sure that you did not create any break, or you did not see any break in this patient.
I just wanted to add one more thing here. Just wanted to take opinion from Dr. Pramod Bhinde. Would you be considering an subretinal Avastin or subretinal air in this scenario? Because
Not
many
really,
people I know.
Not really, because Avastin probably we talk about when we talk about macroaneurysm, anti-VEGF. I don't think there's still conclusive role we agree upon, because I don't think it's have any role, because that's what, see, anti-VEGF we're adding for underlying occlusion or all those things different, but probably per se macroaneurysm, I don't think Avastin has a role, and definitely not injecting here is already, I think, is significant amount of hemorrhage. I do not know peripheral hemorrhages, because heme is still there. I mean, that vitreous hemorrhage is there. Once you clear, we will know what it is, but it looks like having extensive hemorrhage as well. I'm not sure whether it's only posterior pole. If it is only posterior pole, I agree what Dr. Raja Narayan says. But if they're having entire subretinal space is full of heme, probably I just clear vitreous hemorrhage and just because it's looking at already color has changed, alter heme around. So doing extensive retinotomy, clearing entire subretinal space, probably visual potential and is not that great, and also you are increasing the risk of PVR. That's what my assessment. Right. But once you clear peripheral hemorrhage, we need to see how the peripheral retina is.
Can I make a point, Jay?
Yes,
Jay,
please,
can I
please.
make a point?
Please.
Yeah, I would have thought of giving pre-operative TPA and then do vitrectomy for this patient.
That can be another option, yes.
Yeah.
Another option,
Yeah, I mean, I usually like doing subretinal TPA like Alexandra, but yeah, there are thoughts where people inject intravitreal TPA and then take them up, and yeah, I mean there are, but I think that doing a once for all is the best thing. What Alexandra did, right, Alexandra?
Alexandra didn't tell us what she has done in this case.
Yeah,
I know.
let's move on.
I'm
Let's
keeping
move
it
on.
mystery. So
Let's,
it's very interesting because all the comments just point to how many approaches we have to these, right? And it also shows that there's no one great approach. So people have mentioned, the role of Avastin is very questionable in RAMs in general, both in hemorrhagic and exudative RAMs. And then do you do TPA before? Do you put TPA and let it liquefy the clot and try to remove it? Do you do,
subretinal air.
subretinal air? Yeah, and that's, it's interesting because the biggest issue also that comes up with RAMs is, for whatever reason, they're more likely to progress to macular holes as you put, anything under the retina compared to AMD patients. So a lot of Tamer Mahmood work with subretinal air combined with TPA and anti-VEGF is mostly in AMD. He actually excluded RAMs in a lot of his studies. So, and the other, I think, important point is you need to make sure that, usually in RAMs it's subretinal, but sometimes you can have in these subretinal hemorrhages from other etiologies, you can have sub-RPE component, and you want to inject subretinally and be careful. So this is what we did. So we're going to continue clearing. And it looked like there was some dehemoglobinized blood subretinally peripherally. And I'm not showing here, but we did a good depression. And here I'm using intraoperative OCT to find a good spot to go in, because I wanted to make sure I had space and that I was in a subretinal location. And it's interesting, you'll see as we start injecting, for just teaching purposes, you can see you think you're in, but you're just depressing and you're displacing the blood. So you need to make sure you actually in the subretinal space before you start injecting, because you can lose a lot of TPA. And just as we see with, there's a lot of subretinal injections now with gene therapies in clinical trials and not in clinical trials. But TPA tends to go peripherally because that's the path of least resistance. Because posteriorly we have a large clot, but peripherally it's just subretinal fluid and just maybe a little bit of the hemoglobinized heme. So we inject, and we think a little bit is going posteriorly, but not a lot. So we decided, we weren't sure what the visual prognosis was for this patient, and we decided not to work on removing the clot. The other interesting thing that comes up, a lot of patients with RAMs have sub-ILM heme, but I didn't have a very good view, I felt, to work on peeling ILM, and I wasn't sure what the component of sub-ILM heme was. So we talked to the patient. I told him that, the prognosis is not very good, but we tried our best. And this is him several months later. He actually did really well considering. And you can see that it was that RAM along the inferior arcade, the one that was closest to the optic nerve, that caused the whole problem. And all the subretinal blood has resolved. And on a good day, on pinhole, he gets to 2100, which I think is a success for this patient. And to go back to the question, some of the questions were raised. Would you consider now doing laser to the other RAM? Would you treat him any differently or observe? And I would love to hear other people's opinions.
Duras, any thoughts?
A beautiful case, Alexandra. I really enjoyed it. Do you have an angiography done after the surgery to look for further activity of the other lesions?
So we did repeat, and sorry I didn't put it, but it looked, the other lesion looked similar to previously. Yeah, I didn't see any activity.
Okay. So I think it was very nice, but we need to watch.
My thing was, we have treated the effect of RAM, but you see, the cause still remains. Anatomically, we have taken care of the hemorrhage, and patient has been lucky that gained good vision. But we still, I agree with Russ, do an ang and find out other, because the patient had multiple, areas. so that we could treat prophylactically or.
I really just wanted to go back and think about it because a couple of months ago, one of my fellow asked me a very interesting question that when you see a RAM which is leaking on FA, like your case, and what do we do? So the fear is that if you do the laser, you actually might cause occlusion and other issues. If you don't do and it bleeds like this, then you are at risk. So should we be how should we be approaching a case where you see an actively leaking RAM on FA, but there is no as such edema or bleeding or exudation? Should we be still going ahead and treating or praying to God and just observing?
No, if there is no effect, I normally would not. But this patient has bled, so I would try to, do a post-operative.
No, in the beginning, I'm thinking about the baseline, at the baseline.
Masterly in action.
Yeah, that I don't think anybody will,
I think there was something amiss about this particular case because the way it behaved with a central retinal vein occlusion like a picture initially, and then came out with a bleed. There must be something systemic going on in this patient which resulted in this particular massive bleed.
How is the other eye doing, Alexandra? How is the other eye?
He has a vein occlusion in the other eye that I've been treating with anti-VEGF for now several years, and he's doing great. He's an elderly gentleman. He's I think 88, and he's actually a very funny elderly gentleman. He works still, and he wanted the best vision because he works at a gas station with his family, and he's very dedicated. It's interesting. I think to go back to Jay's point, it's very challenging in these cases when you see these RAMs because we're so used to give anti-VEGF for so many conditions, but the data for RAM and anti-VEGF is quite poor. And I think the other interesting thing was that we also taught that we want to go in very rapidly if somebody has submacular hemorrhage. And operate on them if it's a surgical candidate. This patient, we operated because he didn't come in. We operated 6 weeks after we saw him last. And for him, his vision decrease was almost immediate after the injection. So it was probably just the natural progression of his RAM. And I was surprised that even with delayed approach, he did relatively well.
Perfect. Excellent case. I think patient was lucky to come to the right person. Thank you so much, Alexandra. I think
better lucky than good. Thank you.
Thanks a lot. Let's move on with Yoshi. Yoshi, come on, take it away.
Sharing my screen here. Okay.
Yes.
All right. So thank you so much to Jay and the organizers for allowing us to be a part of this all-star panel and this great meeting. And wanted to present a case of total exudative retinal detachment in a patient who's young, just 8 months old. And so the patient comes in because of some strabismus. And you look here, and the pupillary reflex is different. And it's not really leukocoria, but the reflex looks yellowish. So this is xanthocoria. And you could see these are images taken during an EUA. And these are the RetCam photos. And you have total retinal detachment in this eye. Other eye is normal. And you can see that there are a lot of exudates underneath the retina and vascular abnormalities. And here with any bad retinal detachment like this in a young child, we want to make sure that it's not retinoblastoma. And I don't think it's retinoblastoma, but we're going to rule it out. And we do a fluorescein angiography, which I think is really helpful in these cases. And here you see the diffuse telangiectasia and vascular abnormalities here, consistent, I think, with Coates disease. And we do an ultrasound. This worries me a little bit because there's a nodule here, there's a lesion posteriorly, and you have some material underneath the retina here in the subretinal fluid. But the material here underneath the retina is pretty homogeneous, not chunky and of different sizes like you may see with subretinal retinoblastoma. And so these are the images. And my diagnosis here was a total exudative retinal detachment from severe Coates disease. And visual acuity here is a light perception. And although this child is not super cooperative in our exams, I'm just curious at this point, what would our panelists do?
Dr. Bende, we would love to hear from you.
Hello.
Yeah, we can hear you, sir.
Yeah. So yes, I agree with the differential diagnosis we need to roll out, and typically what I can see is like with intraretinal, subretinal, exoretinal fluorescent angiography. My first diagnosis, obviously, I agree with you, will be like a Coats disease. Now, visual potential is practically not that much, but what we have a few cases, we drain subretinal fluid, not as a vitrectomy, because probably sometimes there is no space to enter, so probably transscleral drainage of the subretinal fluid. And once the height goes down, probably we try to do laser to all those telangiectatic vessel. The aim here is to probably, if we can settle down the retina, reduce the exudation, you are saving the eye, probably may not be vision. But there are a few cases we could just, had ambulatory vision, but aim is to prevent the eye going into painful blindness and NVG.
Yeah, thank you for
Great.
your great pearls there. I agree that the visual prognosis is very guarded, so it's important to tell the parents that eye's not going to see very well, and this is about globe salvage and keeping your child comfortable. And so I also agree that, trying to drain the fluid from externally through the sclera is the way to go, because in children, you don't want to make any iatrogenic breaks. Because one, it's very difficult to flatten the retina, which you have to if you want a retinopexy. And number two, these young eyes are very PVR-genic. And so external drainage with anterior chambered infusion, I think, is the way to go. If surgery is what's pursued, I think observation is okay too, depending on, the reliability of the family and how your interactions are. But historically, I think a lot of these eyes were enucleated, but very less so these days.
True.
So here's the.
May I ask quickly, did you show the FA on the other eye, or did I miss it?
Fluorescein is absolutely normal. Now, Coats disease, it's considered a unilateral disease, but us and several other groups have written papers showing that you can see fellow eye findings, but it tends to be very, very minimal and not visually significant. Some little telangiectasia or small aneurysms, maybe in about half of patients. Now with wide field angiography, we're realizing that it might be a bilateral phenomenon. Why it's so asymmetric, we don't have a genetic cause for this yet, but I think we still have a lot to learn about this. But examining the fellow eye is definitely very essential in pediatric retinopathies.
Perfect.
Well, also to differentiate, recently we had a similar case, and my primary diagnosis was obviously Coats disease. When I did ultrasonography, we have a few calcific spots, and we know that in Coats we do get a calcification also, probably, but at a scleral level. But the case which I had recently is showing some calcification in retinal Coats as well. So we asked for MRI, and then they came out to be probably we may dealing with a diffuse retinoblastoma. Ultimately, eye is enucleated. I do not have yet histopathology report this. I'm just talking about what happened last week. One of my colleagues ultimately enucleated. I'm waiting for a diagnosis, but primary diagnosis, exactly the picture is what I said. Primary diagnosis for me was Coats actually. I'm surprised looking at those calcific spots. But anyway, but what you mentioned about enucleation, when you are not sure about diagnosis and when there is no visual potential, might considering young age, probably you more are on an enucleation side rather than trying to do a conservative treatment.
Dr. Bendy, that's a very interesting story because we had a similar situation 2 weeks ago. And at Wills, I work very closely with Carol Shields and her team. And we do joint EUAs and procedures together. And she was referred a patient for Coats disease. But on B-scan, there was a lot of calcification in a similar looking eye, though, with a total exudative detachment. And she had to take the eye out, and it was retinoblastoma.
Oh.
Okay, so this is what we did. So normally, so we do a peritomy here, and we're going to isolate the muscles here so that we have good control of the eye. And here, there was no anterior chamber because the lens was up against the cornea. So I inject Helon to create the anterior chamber so that we can put the infusion in. Instead of AC maintainers, I like putting the trocar cannula system into the through the limbus because it creates a very tight seal. And so that's what we're doing over here. And here, retinoblastoma is unlikely, but it was still sort of in the back of my mind. So I'm taking a biopsy here just in case, so I could send it to the pathology lab. And the drainage occurs spontaneously from that area. And the retinal detachment is improving and trying to express more of that posterior fluid, but not all of it is coming out. this is the important part here. Like Dr. Bende mentioned, the detachment is getting shallower now. So now we're making sure that the pars plana is available so that we can go through. If we wanted to do vitrectomy, most cases, traditionally, I think people would have taken the lens, but here we're making sure that the pars plana is attached now so that we can make sclerotomies. But I'm not going to use cannulas because the space is very tiny. And so I'm going directly into the sclera. And here, doing the vitrectomy, but there's not much vitreous because everything is so collapsed. And so we're not really taking anything out. And this is the cool part, using perfluorocarbon to push the remaining fluid out from inside, outside of the, through the sclerotomy. So we're draining the fluid without making a retinotomy. And now we're able to treat the lesions very well. And the aneurysms and the vasculature here, I'm doing fluid air exchange, and I'm instilling silicone oil in this eye. And it's not a regmatogenous detachment. So if it was a TRD, like for ROP or fever, no need for tamponade. But in this case, I know that the exudation is probably going to come back despite the good treatment with a laser. That tends to be the case for these really advanced eyes. And so I think the silicone oil helps to maintain that hydrostatic pressure to prevent the exudation from coming back. And the retina has been attached under silicone oil for the past year or so. And the child maintains light perception vision.
Excellent case, Yoshi. Excellent. When do you plan to remove the oil, or what is the plan about the oil?
Yeah, you know, you saw that I used 5,000 centistokes. In the US, we usually use 1,000 for most cases if you have plans to take it out. And I use 5,000 if I think it's going to stay in there forever, which is the plan.
Okay. There is a very interesting question from Gopal that intraretinal classification and osseous metaplasia may occur in coats. Any further tips to rule out RB? Do you have any thoughts on this?
I think between, the fluorescein is really indicative. And in retinoblastoma, this is a pearl I learned from Shiz Mukai, but the vessels kind of dive into lesions. Coats, you never see that. So I think fluorescein is very helpful in addition to the B scan.
Okay.
And of course,
On the B scan,
brain image.
you did show the hyperreflectivity that is present posteriorly. I think it's more due to the exudation that has come towards the macula, which I think you saw it in your surgery also. So that is what shows the hyperreflectivity that you see, but never as much as calcification. So you can always say that it's probably exudation that has come.
Yep, absolutely.
Sorry, go ahead, Yush.
Oh, no, I was just going to say, even in mild Coates disease with peripheral exudation, that exudation can track posteriorly into the fovea over time if you don't treat it and get that fibrotic knot where you could go from 20/20 to 2200. And so it's definitely a part of the disease. Vinod, I'm sorry, I interrupted you.
No worries. So I had a little comment regarding silicone oil removal in these cases. So once you see in the follow-up that the exudation is decreasing and the telangiectasia are well lasered, probably that's the time you can start planning the oil in these cases. I've done a couple of cases. They do really well. At least you are able to save the eye. In fact, I had a very interesting young girl who came to us. Being a girl, she had bilateral Coates disease. So she had been worked up for other abnormalities in terms of muscular dystrophies, but nothing came out. So one eye was already bad to begin with, neovascular glaucoma. The other eye had peripheral telangiectasias. So I took her up and did a good, nice vitrectomy followed by laser coagulation of the peripheral telangiectasia. So it's been 5 years now, and she's been doing really well.
Excellent.
That's great. Bilateral Coates definitely is very scary because of all the systemic issues from the muscular dystrophies, some telomere diseases also. And so that's a great pearl.
Perfect. I think we will move on with the next case because as expected, the discussion is too good to avoid, but let's move on with the rest. Thanks, Yoshi. Thanks a lot. The rest, go ahead.
Good evening, everyone. Can you see the slides? Sorry.
This is 2020 special, huh?
Good evening. Thank you, Jay, and thank you, AIS, for this opportunity. So something which is flavor of the day and a case which has been troubling me. Even today, I saw this patient, so I wanted to just discuss about, this is a physician, one of the leading practitioners from eastern part of the country Uttarakhand, and he complained of diminution of vision in both eyes. He suffered severe COVID disease for which he had been admitted, and he lost vision first in the left eye and then in the right eye. He's diabetic hypertensive. He complained of pneumonia, respiratory failure, high fever, hypoxia. RT-PCR was positive. He was admitted for 3 weeks, at which time he got a massive amount of IV antibiotics, antivirals and steroids, and he was on NIV oxygen support. X-ray chest was typically suggestive of COVID-19 pneumonia. So left eye, he had some floaters at 1 day after discharge. And a week later, he presented to his primary ophthalmologist in the town of Kashipur, where he resides, and she diagnosed as a subretinal altered heme. So the initial diagnosis was wet AMD. And then 10 days later, he complained of vision in the other eye. So I'll just show you the picture. So basically what I want to emphasize is, because he came with the right eye with this hemorrhage, it was thought that it was initially thought to be AMD. And when it became larger, then the doctor thought that because he had been on steroids for almost 50 days, and because they were withdrawing the steroids, the inflammation was starting. So he was started again on tablet Vizolone 40 mg, and periocular triamcinolone was injected in both eyes. So the total duration of steroids for COVID and vitritis was 50 days. So you can see this is the right eye with the hemorrhage, and the left eye, this was what initially came up and was thought to be subretinal heme. You can see in the middle also there's a red patch. So this was basically initially diagnosed as wet AMD. When the patient came to us, it was scary because this was a physician and he had totally lost vision, counting fingers 1 meter and in the right eye, and he was just counting fingers close to face, PR accurate in left eye. Pressures were okay, cells and flare in the AC, and a significant cataract. So this was the initial picture of both the eyes. You can see the right shade better, but you can see this yellowish white fluffy exudates in the right eye. You can see the disc clearly. The left eye is much worse. You can see that there are 3 lesions. There's one at the macula, one temporal, and one huge like a subretinal abscess inferotemporally, and the retinal vessels are going over this abscess. So when we saw this clinically, we diagnosed this as endophthalmitis, and we decided, so now first call I'd like to ask the panelists is, which eye would you treat first? Would you treat the right eye first or the left eye first?
Any thoughts?
I think
I don't know.
Both the eyes intravitreal voriconazole, because the picture does not look like a suspicion of fungal is pretty high.
I agree with Dr. Lalit Verma. Why not both eyes? I mean,
yeah.
I
don't think that, this is not a situation that we choose one eye or the other. Maybe alternate day, if not on the same day.
So this is the rare indication of bilateral vitrectomy. Alexandra, any thoughts?
Well, I think it was interesting, because this patient obviously is immunocompromised. He's been on steroids for a long time. He's been in the hospital for a prolonged period of time. So I was just a little surprised to see that with such vitritis in the left eye, the thought initially that it was maybe AMD. I think the suspicion for this patient is extremely high. And I agree. I probably would tap and inject when, the day I see them, and then start planning for surgery. But I wouldn't even wait for surgery to tap and inject, as others have mentioned.
So initially,
this brings another question also. Has the COVID become negative before you started treating him, or was he still on COVID?
No, COVID is negative now.
Negative.
Yes.
So if the COVID is, I have one patient. The reason why I asked is I have one patient who is recently turned COVID positive when he was planned for an endophthalmitis vitrectomy. So what's your thought process now about that? Do we have some protocols on that?
I think we should still go ahead and do with all the precautions, because people are still doing their emergency surgeries, and this is definitely an emergency surgery.
Yeah, Gopal, because this is an emergency, I don't think so. The line of management of vitrectomy would change with regard to RT-PCR.
So we did operate one eye, and at the same time I injected antifungals in the other eye. So this is the surgery of the right eye, which is the better eye. As you can see, this is a huge amount of exudates And the interesting part is the abscess, which even when we remove the posterior hyaloid, you see a lot of the exudates come out, but that abscess remains at just below the macula. And so I think we can move on. And left eye, of course, was done just a few days after the right eye. This left eye was much more of a challenge because the lesions are much more extensive in the left eye. So you can
just a quick question. How many of you would be very comfortable in inducing PVD in patients with active endophthalmitis like this? Any thoughts, Raja?
Yeah, I would go ahead in this case, although it would be a very gentle and careful induction, but I would go ahead with PVD induction.
Okay.
By and large, I would also agree with Raja.
Yeah.
We try to induce PVD because especially if the predominant exudation is below that, so we should try.
And I
There's
just
also
wanted
on visibility of what we are trying to do, and also the ease of the PVD coming up.
Yeah.
So we should not force it.
Don't be too dramatic. Yeah.
So
yeah, I just wanted to bring Dr. Lalit Verma's. I remember, sir, you used to talk about using oil in endophthalmitis.
Yeah.
So I would request your few comments about this.
I thought let us see this video, then I'll comment.
Okay. Yeah, please. We would love to hear that.
Sorry, at the posterior pole, there are some hemorrhages and this yellowish clump-like thing, which is becoming a scar. And then there are two separate masses. And if you can make out the inferotemporal one is really bulging out. It's like a large abscess. And then there are all these, what we feel are like fungal colonies, these fungal balls are there. And in this case, yes, very good, aptly brought up by Jay. This I did use oil after doing a fluoride exchange in the left eye. So that is also something we could discuss. So right eye improved to 6/24. Left eye is counting fingers. Vitreous cavity is clear. The scar is forming in the right eye. And the left eye shows scar formation at the posterior pole with decrease in the size of the abscess in the inferotemporal quadrant. This is a post-op picture. Right eye, you can see, is doing quite well. This has become a small scar. Left eye, the posterior pole is scarring. The temporal lesion is becoming smaller. Inferotemporal one is really going down slowly. So I'd like to take the opinion of all my seniors and other colleagues about how to handle this eye. Just a quick look at the OCT, the pre-op OCT of the right eye. And you can see this mass. You can see these what we thought were fungal balls or exudates in the vitreous cavity and the attachment of the vitreous left eye. It's looking quite nice post-operatively scarring down. And the left eye, this was the pre-op OCT, not very clear, but you can see this huge mass lesion and slowly is coming down post-operatively. The patient grew candida on the blood agar plates, and these are the creamy white lesions. A gram stain showed the budding yeast cells, which are seen well. And thanks to the laboratory of Shankar Netralaya, we got a PCR which was positive. And when they did the PCR-based DNA sequencing, they also identified Candida albicans for this patient.
Yes, the right eye after vitrectomy, did you give voriconazole?
Yes, sir. Yeah. So both eyes gave voriconazole.
No, post-operatively also, did you continue it?
So in the right eye, we gave it once post-operatively, but left eye now 6 times weekly. Every week I'm giving it, so it's been given 6 times. So right eye has had it at the time of surgery and once post-operatively, and is now seems to be doing well. But left eye, I'm continuing to giving the intravitreal voriconazole.
I'm sure this patient must be having oral voriconazole.
Yes, oral also is continuing, sir. Oral 200 milligram BD is continuing. Yeah. But how long should this go on? That's what is the longest anyone has treated this sort of things with voriconazole? And
actually, Candida responds very well to voriconazole. I mean, I see you are lucky that you got a Candida, not a as this one other fungi, I would say rather. And generally, even their reports, they are giving even up to 3 months continuing, because systemic medication, intraocular, I'm not talking about systemic medication. You can continue up to 3 months. Of course, you can keep on have your liver function test and your other parameters checked periodically. But voriconazole is fairly safe drug compared to amphotericin B and others. That is one. We had another case, what you saw left eye. It was not, of course, COVID era, but I think Muna operated that case. Intraoperatively, because of that huge mass, subretinal abscess, we decided to anyway overlying retina was a little bit necrotic. So just try to drain intraoperatively that single abscess. Okay, flatten on the table and put the oil in that case. Fortunately, patient is doing well, but extremely hesitant while doing that. If given option, I will be hesitant to create a break. Also, as Gopal said, easily PVD coming up, I would take out, but I will not force induce. But that case, it work out. Here, I think we just have to wait till that thing set up. Macula is okay now. So I think the peripheral abscess, you will have to continue systemic riconazole, and I think it will settle down.
Can I make a comment? Yeah. Can I make a comment? Yeah.
Yes, please.
I had similar cases of bilateral candida endophthalmitis following patients who are on dialysis and have a central line. They are increasingly predisposed to it because of the central line, and they develop this. So and very similar appearance of them, but they do settle down. I did get pretty good vision on them in both the eyes. They do respond. The abscess that you see peroperatively tends to come down, very well. I think because it's a very sensitive organism, it is very sensitive to antifungals.
Yeah, I would just like to share our experience at LV Prasad Institute. Great case is a great case that has. I had one patient who actually presented with 20/20 vision, one just small subretinal abscess. I went in, just above that abscess, tried to take a biopsy sample, injected, started treating him, but in spite of that, he worsened under my care. But overall, what I would say is, we have now Dr. Samira Nayak, who is my colleague. She has collected about 33 eyes of 24 patients of COVID-19 presenting with endophthalmitis. And out of those, invariably, 80% of them have got fungus, and most of them were candida. Just a couple of them were aspergillus, and one was mucormycosis from paranasal sinuses. But the main thing is what Gopal asked, do they have an active COVID infection at that point of time? And if yes, they have a very high risk of mortality. 20% of our patients died. Now that's a huge number when you compare the overall mortality of COVID. So patients who are coming in an ambulance with the oxygen and they have this end of problem, they are at a very high risk of mortality because they are all immunosuppressed for various reasons. And if they are on steroids, they have to be stopped. But again, the COVID problem increases. But that's one thing which we need to be very much aware of. But if it's post-COVID, let's say beyond the recovery time, then the mortality is not there. But obviously, and only 50% of the eyes actually had less than 400 final visual acuity outcomes. So they all kind of go blind after this.
No,
Great.
Just last comment. We are getting short.
What I was saying was that it's a great management, what you have shown, Dries. I would have also done the right eye first only, because that was the potential better eye and could have saved. And my indication of silicone oil, as Jay was pointing, was that I definitely induce a PVD and try to induce PVD in majority of the patients of endo. And without PVD induction, I would not inject silicone oil. So silicone oil does help to salvage a lot of these patients of severe endophthalmitis. And I have operated one of the COVID, fungal end of candida. And as was being pointed out by Pramod, you have to continue voriconazole for at least 2 3 months.
And one quick question, sir, when would you like to start topical steroids? Because the point is they have some cells flare and the pressure is going up in the right eye now. The pressure became about 30 in the good eye, the better eye. So it could be because of the inflammation, but we don't want to start too much steroid because of the fungus. So any guidelines on that?
Yeah, what I do is that once you have, once the patient is on antifungals, then topical low dose fluoromethalone drops, and more importance is for atropine actually. I do start.
Okay, thank you.
All right. I request to respond the questions on the chat because we are getting short of time. Let's move on. Thanks, Darius. Thanks a lot for the fantastic case. And let's move on with macular surgery by a fine surgeon, Dr. Murthy.
Yeah. Hi. Let me just share my presentation. Yeah. You're able to see this?
Yes.
Okay. So I would be presenting on macular hole retinal detachment, which is always a challenge in most patients. But here, the challenge was much later. This is a 47-year-old lady of a myopia of -22. She has been on long-term follow-up, perfectly good health. She has no diabetes or hypertension, and she used to I mean, she didn't look as if they had any systemic problem. Vision was 624 in both the eyes. Fundus showed some myopic degeneration with vitreous floaters. But in July 2020, she complained of sudden blurring of vision in the left eye. And the vision had dropped to 3/60 in the left eye, and the right eye continued to be 636. At this time, when we see the fundus, you can see that there are myopic changes. There's a crescent and some focal myopic degenerations. But when we did the OCT, there is a dome-shaped macula with some subfoveal fluid. So assuming this to be the subfoveal fluid of due to the dome-shaped macula, I said, let's see. The other eye, the left eye, which had the symptoms, showed that there is a dome-shaped macula similar to what is there in the right eye, but you could see a macular hole and there was fluid in the entire inferior quadrant. And when we did the OCT, showed a small macular hole and there is subfoveal fluid. And we assumed that, yes, there is a macular hole retinal detachment at this stage. And we took up for surgery. And this is the surgery. As you can see a lot of fluid inferiorly. And I first removed the hyaloid from the posterior pole so that there'll always be, there's no PVD. Most of the posterior hyaloid is adherent to the retina. So we need to remove it carefully. So after that, I did go about, removing the posterior hyaloid all over. We need to restain with triamcinolone fairly frequently. You can see that the retinal detachment is involving the entire temporal inferior quadrant. And it required a lot of, careful evaluation and peeling off the hyaloid, which did well. So I know because I did use a 25 gauge. This is a 25 gauge vitrectomy, although it is minus 22. I could still reasonably do a good job with 25 gauge. After inducing all this, the surgery is fairly otherwise routine. We peeled the ILM, and at the end of surgery, the retina flattened out and it was fine. Sorry. And on the post-op day, patient started improving, and once the gas disappeared, we could see that the hole was closed. There was a problem prior to surgery wherein we observed that patient had high blood pressure, but patient said that she has no history of hypertension. Anyway, we kept that in our observation. She had borderline random blood sugar. So we controlled the hypertension and the surgery was done, and the patient was given a reference letter to the physician asking her to see the physician because there seems to be some problem in her health. But on the post-op day, in post-op 1 month, the retina was looking good. There was no subretinal fluid. The hole was closed. Everything was looking good. 15 days later, she came with some spongy thickening of the retina. Now you can see that there is spongy edema. In one side of the maculas the holes are continued to be closed. We said, let's observe this and see what's happening. She came a month later complaining that there is a dark patch in her field of vision, and the vision was still 6/60, but she's saying that I can see a dark patch. And when we see now, there is a subretinal fluid and a lot of edema, which is intraretinal edema with hyperreflective dots, which started appearing. So we know that there is some systemic problem that is occurring in this patient. So we asked her whether she had seen the physician, and she said, I have not at all visited the physician, although we had given her a reference letter. So at this stage, we advised that, let us go through all the systemic investigations. And to our surprise, we find that she was anemic with a HB of 7 grams. The HbA1c was fine. The ESR was high. She had a creatinine of 6.8. So we asked her to immediately see a nephrologist and to see that she's, undergoes complete evaluation and treatment. When she came back, she had seen the physician and they had managed the anemia. So her blood hemoglobin had improved to 11.6 and the hypertension was on control. And we now see that the retina started looking much better. The edema had disappeared. There was no fluid. So this is on the left eye. And the right eye, the subretinal subfoveal fluid, which was there, also disappeared. So now we come to an important thing that, we know now that a lot of the systemic condition was probably responsible for some part of her condition. But did it play a role in the initial presentation? Because now looking back, I think both eyes had some degree of fluid, whether that triggered the onset of the macular hole detachment, because we know that the inverted Muller cone cells are, tend to give way once there is some sort of a problem in some of these patients. So this is what
I don't think
Nice.
that the initial thing was related to the hypertension, because I think in that case, immediately after vitrectomy, I had a rebound.
Good closure.
Yeah, exactly. So
Yeah.
I think so. But you're lucky that the patient did not have any intraoperative problems, systemic problems, emergency during surgery.
Yes.
I mean, controlled blood pressure and anemia and high creatinine. So that way, I think you're fortunate that the
We
patient.
enjoyed your surgery, Hemant.
Yeah.
It was good.
Yeah, very nice. So Raja, how do you take care of the post-operative CME in addition to the systemic control of the factors which Dr. Hemant nicely showed? How do you deal with the post-op CME?
Yeah, so this was not just a post-op CME. I would like to just, I mean, I don't have an exact diagnosis, but my first thing would be to do a fluorescein in this case when you saw that edema, and not OCTA. I know you may have comments on Opta, but I would not believe in Opta in this case. Definite fluorescein, look at probably one of my differentials would be a macular branch occlusion. And sometimes in such high myopes, it's not easy to pick up. But I think it's one differential. I can't say that it is the case. But fluorescein will tell us where's the leakage, what kind of pathology. I'm suspecting a vascular pathology, looking at the kind of edema, the localized edema, high reflective dots. Sometimes in these patients, it may be easy to miss a small vessel occlusion. But overall, I think the surgery was done very well. Sometimes you do get these edema, if you get back, then it can cause reopening of macular holes,
Yeah.
Especially if it's a CME kind of thing. But you are fortunate that it has not happened so far. I don't know, what was the treatment that you gave? You showed us some investigations, systemic, but how did you manage it?
No, the management was done essentially by the nephrologist. So they started controlling the blood pressure first, and they said that she would have to undergo dialysis. So prior to the dialysis, she came to us and she started showing improvement just with control of hemoglobin and the blood pressure.
Wonderful case,
Sunil, do you?
Hemant. Wonderful case, a lot of learning for control of creatinine and BP and all. But you see, two cases I remember where I did face this spongy kind of edema. So in this vitrectomized eye, I injected Ozutrex actually.
Yeah,
Because the other things were good. Honestly speaking, I didn't investigate, but the preoperative, hemoglobin, everything else, or the stable patient, everything was very good. But for some reason, they did develop this spongy edema, and I was happy to use Ozutrex with the good result.
Sunil, do you have any quick comments? You are muted.
Yeah, no, I think the comments that, I agree with the comments that my colleagues have made. I think it's a really interesting case, and there's a lot of different sort of choices to make, and it's nice to see how creative people are in getting these kind of cases to have a successful.
This case really brings down to that we need to really look at the systemic factors. Excellent, thank you so much. And let's move on with the next case by Raja. And Raja is going to show a surgical case not managed surgically. You're muted, Raja.
Sorry, I'm here to make up lost time for you if you are worried that
No.
we are running out of time.
I like to finish the meetings on time, so we are going good.
Yeah, so it's just like 4 slides. It's more of discussion. I'm not going to show any videos. So I'm trying to convert surgical cases into medical retina cases. This is a 23-year-old gentleman who had presented to us with a history of blunt injury, and as you can see, there's a macular hole. 20/40 vision, a very small hole. And this was in 2019. And I had just started on, let's say, topical medical therapy. One way to look at it is just leave it and observe. But I thought, let me try to push it, or whether it's a placebo or a real effect, I don't know. And I will just come back to the ophthalmology retina publication in December, where they published a large series, not a very large series, but they did prescribe these what I had already done. And then lo and behold, this eye's macular hole closed, vision improved. So the debate here again, I would like to ask the panelists, how long would you wait, and is just observation good enough, or would you like to use some of these topical medications? Because as per the publication in ophthalmology retina, these eyes, if you treat them with NSAIDs, steroidal drugs, as well as brinzolamide, they use brinzolamide, the closure rates were 3 to 4 times than what is seen as spontaneous closure. So I'm just trying to see whether we should debate usage of these drops. This is another patient with an idiopathic macular hole. This is not post-trauma, as you can see, an elderly lady about 60 years old. And when she presented to me, this OCT was done elsewhere a year ago, and she was told that she has to undergo surgery, and that's what I would have also advised if she had come to me with the same scan. But I thought I did not see a macular hole in clinical examination, and obviously I repeated the OCT scan and look carefully at all the scans. There's no macular hole, and the vision is also probably improved. We did not have the earlier visual acuity, but obviously the hole has closed. So in this case, she did not use any eye drops as such. So in the first case, I showed a case where we used some eye drops, and in the second case, there were no eye drops which are prescribed, but you can say that they were non-surgically closed, whether it's spontaneous or not. Like in the first case, we used some drops. But my question is, at this point of time, are we looking at least in the small macular holes, are we looking to see if we can use some medical therapy and give it, let's say, about 4 to 6 weeks, maybe a little bit longer in traumatic macular holes, but should we give a trial in small macular holes and then look for surgery?
Very, very nice case. Raja, there were when I looked at this case of yours, it just definitely shows the recent discussion on topical drops. The first case was traumatic. There was no vitreoretinal traction. There was no vitreomacular traction, and it closed with the drops. In the second case, the vitreomacular traction was there in the OCT elsewhere, which possibly got released. So I had a question for Yoshi, that Yoshi, have you experienced this new concept of trying the topical drops? And if at all, then where do you particularly use them?
Yeah, great cases. And I think that when you treat a surgical condition medically, that's when you feel like an amazing surgeon and patients love you. They think you're God. And so I think this is definitely something we should strive towards. I think that the topical drops, I do use them for certain configurations where there's a lot of hydration of the macular hole, a lot of cystic spaces. I think, and smaller cystic spaces, I think those are cases where the drops work really well. However, in your two cases, personally, I wouldn't have done anything because the first case was a traumatic macular hole, and in traumatic macular hole, usually they're younger patients, but still relatively young here, hyaloids attached, small hole. The hole's going to spontaneously close more than half the time. And here, you asked a interesting point about when to intervene if the hole doesn't close. Usually for traumatic macular holes, I wait 2 or 3 months. But if there's any improvement on the OCT, I think following by OCT is really, really critical. If there's any improvement, I keep on watching. And the second case here, I think it was more the AP traction that was released by the PVD induction. And so the patient maybe went on a roller coaster ride or something, which can be a prescribed treatment as well.
Yeah, we see, I had a patient with vitreomacular traction. I advised surgery, and then summer came. He said, okay, I'll just play around a little bit, and he comes back. And we see a lot of PVDs during summer. So I think that helped him to close the macular hole. So I have started exercise with vitreomacular traction. Dr. Rana, any quick comments?
Jay, can I show a case after that? Just a quick clip, just one slide.
Sure. By then we will hear from Dr. Rana. You can go ahead and share, Dr. Murthy.
It was excellent series, and actually we should have like something like maximum macular hole width which we can wait for. So we should do a study on this. So which can be the minimum size where we can wait, and which can be the size from where we can just go ahead for surgery. We should do a study on this. And it's actually a great thing to actually what he did.
Fantastic. Let's see what Dr. Murthy has. A quick 2 minutes.
So this patient came to us with a vision of 612, complaining that she is now dropped in vision in the right eye. And when we did the OCT, she was advised macular hole surgery elsewhere. But when we saw her, we saw that she seems to have, the PVD seems to have occurred, and the inner wall seems to have closed. There's only an outer wall defect and a sort of cyst. Probably there was a vitromacular traction, which seems to have released. So we said, okay, let us wait for some time. I said, just come back after 1 month. She comes back smiling 1 month later, and macula looks absolutely normal. And one can see that the PVD which was there, which we observed, probably is the only reason why I think we said, yeah, this is the reason what must have happened. And that is the closure of the macula.
Almost like an aborted hole.
Yes.
It got aborted while formation.
Yes.
Excellent. Thank you so much. Let's
point. I mean, basically, I think this is a very important point. Actually, therefore, in patients with small macular hole where the PVD is not induced, I think on the day of surgery you must do a OCT. I normally do a OCT on the morning of surgery just to check whether the hole is still there, because we are not going to examine the patient on the operating table. We are just going to get him. So,
great point. That's really great. All right, thank you so much. Thanks, Raja. Let's move on with Vinod's exciting surgery. Vinod, please share your screen.
I saved you more than 2 minutes there.
Yeah, I'm thankful to you.
Am I audible, and is my screen
Yes,
visible?
please. Yes, please.
Okay, so this was a little unusual foreign body I came across. So this was a young male who was finger counting in the right eye after a corneal tear he presented to us. So you can see a entry wound over here, and dense vitreous hemorrhage. There was no view of fundus. The long foreign body, which was like standing like a peg missile in the posterior segment, and it was reaching almost up to the posterior lens capsule. The lens was absolutely clear, and on CT scan we could see that there was a posterior perforation as well. So this is on the table. You can see the anterior end of the foreign body is almost visible behind the lens. So did a 25 gauge vitrectomy for this patient. So after clearing the vitreous hemorrhage, we can see that there is a foreign body which is there. So I usually make a separate retinotomy for sclerostomy for removing the foreign body. So just held this with a forceps, and it came out very easily, aligned it and took it out. So it's a really long foreign body, and the challenge was to preserve the lens. So it was around 15 millimeter long. Now the next challenge was to contain the perforation. Now, once I went back, did the PVD, I did air fluid exchange under a very low air pressure, say around 15, and then just lasered at the retinotomy site. When I came out, I could see the subconjunctival air, but I did nothing, just closed the ports and put 25% SF6 gas. So I'm sorry. So this is how it looks like in the post-operative period. The patient gained 6/6 vision. The lens was clear. And if you see, this was the side where it was embedded, and it had nicely scarred up. So this patient, in fact, did develop nuclear cataract almost 1.5 years after the surgery, and underwent cataract surgery for the same, and the patient remained 6/6. So this is just a short presentation how I diffused a torpedo.
Excellent.
Wonderful result. Yeah. Wonderful.
Very nice.
Very nice.
Very nice. Sunir, any thoughts?
It was similar to the IOF case. It's great that your patient did so beautifully with just a gas tamponade, and I think these cases where it doesn't violate the lens capsule, as much as obviously our goal is to remove the IOP and keep the retina flat, it's nice when you can keep the natural lens in place. And so beautiful job.
But do you believe that anybody would actually try going behind all the way and trying to stitch it from behind the exit wound?
I think at that point, I think in this case it's really posterior and you can do it, but there's a trade-off between you're trying to close the hole and rotating the eye that much. There's going to be pressure on the globe. And so I think going back that far to close it was maybe an unnecessary step.
Because I'm just thinking that, okay, that means Vinod could manage it with the gas, but what if we end up using oil? And what are you going to deal with the oil with? So that is the next round of challenge.
In fact, that is the reason why I did not want to put the oil.
Yeah, I agree with Vinod, because going in an oil, and if it goes in a in orbital space and post-retrovalvular abscess, it's a messy affair. But generally, what you have, even 4 or 5 days of time, you have a fibrosis around the exit wound. And if you're careful enough, what the point he has rightly mentioned, he like around 15 pressure, low pressure he was working on. So he did not exert any pressure. So what happened? Probably that remains sealed. Even though foreign body come up, but we have a fibrosis around it, just maybe gas partly would have leaked. But I think that holds on, I think, extremely well handled case, I would say. Most of the time is not necessary. Maybe I had an opportunity to suture once. I tried externally going foreign, but what happened when the wound is leaking, sometimes you try to rotate the globe around, globe keeps on collapsing, your anatomy is distorted, visibility is compromised. There is a case, eventually we suture that from inside, took the suture inside. That was a heroic effort. Sometimes there are reports putting your spine, just scleral piece, going inside and plugging in that, or sort of things people have tried. And now amniotic membrane, somebody is trying there. Yeah, there are options, various, but most of the time, if you give 4 or 5 days, if you're doing immediately after injury, yes, the wound is open. Then you are land up in a problem. But if you already have a 3 or 4 days are gone, and if you are careful enough and see that you are not distorting globe during surgery, I think you can hold on well.
Great. Anybody else has any quick comment?
Yeah, Vinod, I don't know if you can put up your slide again. I was extremely interested in your OCT post-operatively to look at the sclera, because what Dr. Pramod Bende also mentioned, that there can be post-operative scar of fibrosis at the exit site. But looking at this sclera, I don't know if you could see all the scans. It didn't look like there was any perforation posteriorly, but it would be good to know, how soon it causes scarring. And it doesn't mean that during the surgery in a fresh wound, it would be closed. It may still be open. And especially if you put oil, it's likely to go into the retrobulbar space and then come anteriorly.
Further, you may not be lucky every time. No, you may not be lucky every time. You see, if it's a large wound, something maybe requires something, what Pramod was saying, amniotic membrane or something.
Yeah. You have to be prepared for everything. You never know where you are going to land up. You have to be prepared for everything.
Yeah.
I had a case where the foreign body was actually stuck in the posterior wall and I had to really remove it. So obviously it was an open wound when I closed it. So if the foreign body hits it and comes off, that's all right. But if it actually goes and stuck there, you have to really take it out. So I think doing a CT scan preoperatively certainly helps to understand the amount of foreign body which is in the wall or outside the wall, and that can actually prepare you for the surprises. All right, so let's move on with the next case. Thank you so much, Vinod. Very exciting
One
case.
second, may I just interrupt? So
please go,
the case that you are trying to tell, Jai, is a patient in whom there is a sharp thing which has gone and stuck inside the choroid and the sclera. Once you take it up, you are thinking that the silicone oil will move back. I just want to ask the panel, in a sharp wound like that, how many people have actually seen silicone oil going into the post? I'm not talking about large perforation posteriorly. It's a sharp which has been stuck and you have removed. How many of the panel have seen silicone oil moving into the orbit?
Yeah, but why you need a silicone oil?
Yeah,
sir.
Why do you need a silicone oil when you have, if you are sure there's generally these wounds, posterior wounds, they generally do not leak. And around the perforation site also generally there is a scarring, chorioretinal atrophic patch, and heals on its own. Most of the time, even tamponade also is not necessary. Though we do
Absolutely agree.
laser because you want to play safe, but generally these wounds, they do not leak. Once you give enough time, weeks time and 10 days time, generally they do not leak.
Absolutely agree, sir. But if there is any other reason why we would want to use oil, I think that should not be a predicament.
No. It's see, you take a case to case. That's why Dr. Lalit Verma, what he said, you have to be prepared for all possible options.
Yeah, it just get messy, I guess. Anyway, let's move on with Dr. Bhende's case. Thank you so much, Vinod.
Thank you, Jay. Thank you.
Yeah. Can you see the presentation?
Yes, please.
Yeah. So basically, what you have is a 1 minute. Just let me move this. So this is a 40-year-old male reported to us actually 2015 with a mild reduced vision in the left eye of 6, 9, and 6. Right eye vision was okay, but on examination, what we saw is both eyes is having angiomas, systemic history and family history was non-contributory. This patient underwent over a period of 3 sittings of TTT in both eyes at a 3 to 4 months interval, and then he was doing fine. So this is a picture at a 3rd visit. He was holding on well. Then this is a 7th visit over a 3 years now. Absolutely fine. Angiomas are scarred, though left eye had some exudation here in the nasal side. But this was like a 17 January. In 2 months later, he comes with and vision is maintained here, both eyes 6, 6, and 6. And then he comes back 2 months later with a left eye sudden drop in the vision. This was like our fundus drawing, total detachment in the left eye. Right eye is fine, holding on throughout till now. And this is 2018, having exudation, complete total retinal detachment. Obviously, it was rheumatogenious, and this is what we did. I think you see the video playing.
Yeah, we can see.
Have a vitrectomy we did. Lot of subretinal, intraretinal exudation. This was one angioma here. This is another angioma, and this is a big another angioma. So we try to induce a lot of fibrosis, as you say, and when you try to trim, you see these dilated vessels and feeder vessels. Vitreous was stuck. Lot of fibrosis. Try to peel the vitreous off. So as much as possible, as much we could do. And this is what started oozing here. Well, I forgot we did case in under local anesthesia, not a general anesthesia, not a hypotensive anesthesia. And then trying to peel this fibrotic vitreous off. I won't say membrane, but basically it's a fibrotic vitreous. Managed to get this out, and you see amount of fibrosis these cases can have, and this can be really, really messy. And most of the time, you have a breaks at the base of the angioma. That was, I was cauterizing one of the feeder vessel, and this is what it started oozing now. When this age, because of the posterior hyaloid, when you try pulled and you create a break along the edge of this posterior margin of the angiomas, it started oozing here somehow. Raised bottle high pressure, then eventually did a fluid air exchange. In spite of that, it was oozing. So what happened is ultimately I had to do a mechanical pressure holding my cutter right over that feeder vessels. So initially, generally we plan cutting the feeder vessel and then like a draining vessel. When you see, even with fluid air exchange and pressure of almost 70 or 80, as you see here, it's still oozing, active bleeding. And so eventually what I did is I just keep direct mechanical pressure, keep pressing on that vessel, holding for a while, and eventually it stops. So waiting for a few, maybe minute or two, re-injected the fluid. Of course, during that phase, I touched the lens, and subsequently, now this is a phase, whole thing as fibrose. To relieve the traction, I don't have choice but to do retinectomy along the posterior margin of these angiomas. These are one vessel. This is another vessel. We have 2 vessels here. We'll come to get later on. And this is what I was doing. Retinotomy followed by retinectomy, this entire peripheral retina, and then of course, resection of the angioma. And then when you come for this big angioma now, this is one vessel. And what I aim at doing heavy cautery to actually ensure that you disconnect the vessel directly, like not like a trial cautery and then try to cut on it. Just my cautery itself is I'm going to just sort of separate the vessel directly from that angioma place. So probably that is relatively safer, though still it can cause some amount of bleeding. Sorry, we go back halfway through. So, but eventually, as it's, sorry, again, I don't know why it is moving, suddenly jumping forward. So this bleeder, again, that vessel eventually gave way, but I could control the bleeding. One more time, fluid air exchange to stop that bleeding. And once that was done, as you see, yes, in between it one like little bit, you feel your heart is at in your mouth, whether I'm going to able to, so fluid air exchange, remove the air, and then cleaning job for clearing the heme. And this is what you have, retinoschisis also, and you have subretinal clot. Remove the entire clot here. Took little bit time to clear it off because he didn't want to tear retina further, and also did not want to have traction on those fragile, those vessels which were just close with coagulation. And once you remove this clot, then it was easier because now no more blood supply to that angioma. So I just chew off entire angioma after that. Okay, and that's what this is the angioma. Now, see, probably because it's become a vascular, there is no more blood supply there. Completed the retinotomy all around. And once we have then reflected the retina, we have some subretinal blood clots because of long-standing detachment, had some fibrous band also. Those are removed, as you see here, followed by PFCL injection, flattening the retina, and laser all around. And this was picture what we could settle the retina at the end. And this is the fourth post-operative day. Subsequently, we followed. Now it's a 3-year follow-up. This January patient come back. He is maintaining 636 vision in the left eye. Right eye is still holding on throughout, but left eye is now, he's still maintaining 636 vision. Pressure is fluctuating between 10 and 8. The last pressure was 8 millimeter of mercury. Near vision is N12. And in between, because we have to remove the lens, secondary IOL implantation also was done. So he is stable, no silicone oil emulsification, and I have decided not to remove oil as of now, just following him. Thank you very much.
Excellent case. Dr. Benick, I would like to share one of my cases. By the time, let's hear from Yoshi if he has experience with this. And I'm going to share one of my 1-minute video on this. Yoshi, any thoughts?
Yeah, what a amazing case, amazing surgeon. You know, there's so many learning points in your beautiful case here. And I think these are the most difficult retinal detachments to fix because it's rhegmatogenous and exudative and tractional. And so you have to take care of all of those forces. And if it's milder, what I prefer doing is using a scleral buckle and buckling all the big tumors, and tractional detachments can settle that way. And it's easier to laser also using segmental buckles. But here, I think everything was too diffuse. And when you do a vitrectomy, I think you just have to be as definitive as possible, which you beautifully did, getting all the hyaloid off, getting all the traction off, and then those tumors, you had to take them out. And I think the direct pressure, that's a great pearl also of bleeding that just doesn't stop. I think all bleeding can be stopped, sometimes at a cost, but here there's very little to lose, and that was a key part of your surgery too.
Excellent.
But beautiful case.
Yeah, thank you. And Yoshi, I am Dr. Bhende's fellow, the amazing surgeon you saw. And I saw this patient back in LVPI a couple of years ago. It was a young guy with diagnosed as uveitis, complicated cataract, couldn't see anything, got a B scan done, couldn't make out much. Yeah, there is a detachment. So I finished the vitrectomy and I get shock of my life and I see this. And I thought, let's do something different. And I ended up putting a proline suture because I could not dare to cut the angioma. I thought, let's do something interesting. And I ended up putting a proline suture, and I did the fibrotic ligature of the feeding vessel, as you can see here. And this was something which I had never seen, never heard of. And I ended up doing this, and to the best of my surprise, everything really went on well. You can see no bleeding, nothing. I fixed the retina, and this patient really did well. And 3 months later, he ended up having a recurrence from inferior part. Then when I took him in again, and as you can see that when I was doing the second surgery here, the whole thing was fibrotic, and I went and did the retinectomy and removed this angioma. And this patient eventually did really well, almost 20/100 till I saw him, and we had almost a follow-up of I think 3 to 3.5 years. So this is something which I thought I should share of a concept of fibrotic ligature of the feeding vessel. This was something interesting.
Jay, you are lucky because Mahesh and I used to do previously long back, and whenever we try to ligate those, this angioma will draw blood supply from somewhere else. They just don't leave it.
Yeah,
So
I was lucky because it was a solitary angioma. If it was multiple angiomas like your case, I don't think we can think of doing it. It was a solitary angioma, so I was lucky.
Yeah, Dr. Yoshi, what he said, actually, yes, first choice, and generally quite sometime rather than dissecting angioma, sometime we do buccal. I have a couple of cases maintaining 6-7 point vision, but both vitrectomy and supported with a buccal from outside, because certain angioma, they are so big, and they are in choroid also is a part of it. There are reports suggesting that you scrape choroid and retina angioma off, leaving bare sclera as well. There are reports. But that's a too extensive a surgery. So, but yes, buccal is definitely an option if things work out.
A segmental buccal and vitrectomy combined is a very good approach. So,
Yes, yeah.
Any other thoughts?
One question I had. I mean, is it? I mean, you control the bleeding, but I mean, has it happened that you have not been able to control it?
Well, not yet, sir. Because what happened? I don't remember that ever I lost case because of 8 or 10 or 11 cases maximum I would have done now, but not remember ever I lost the case yet because of bleeding.
So would you have considered injecting PFCL earlier?
No, because see, I wanted to remove all the membranes, and see, when you have already breaks and you're already trying to actively peeling the membrane up, which is fibrotic, there is a possibility that PFCL may will end up entering the subretinal space, pulling here and there, and then remove all that become messy. So
you see,
unless I am sure, I removed the membranes.
Yes, sorry. Immediate, impulse is to inject PFCL, but we should avoid that because it will go into subretinal space.
And also PFCL does not work really as a tamponer because PFCL does not have as high surface tension as you get a gas or air. So it's not a good idea to stop bleeding. PFCL doesn't really not that a good
yeah.
But yeah.
Yeah, PFCL is a good third end only once membranes are off.
Yeah, correct.
That's right.
Any quick comment?
Yeah, I think I presented a case in LVPI masterclass surgical symposium we had. So I've done around 5 cases now. 2 were really bad to begin with, so they did not do well. But subsequent cases I started doing earlier. I did 3 cases, and all of them are doing well. It's really difficult to eat them up. So now nowadays what I do is I increase the pressure intermittently to 80, and then cauterize the surface of the tumor. And once it is stopped, you can start dissecting it again with the cutter. So with the help of 25 gauge cutter only, I've been able to dissect all the tumors I've done till now. So we don't have the time, but I would have loved to share the video. It's a little longish.
Perfect. Yeah,
Sir,
maybe
so
next
that
time.
is what I asked, sir. Why we could not use the diathermy on the surface when it was bleeding, even on the angioma? Will it not stop?
It will.
Well, because these are the high flow lesions, very, very high flow lesion. And see, you may not get time that enough to whole thing coagulate together because tumor is large. Even those larger vessel, as you saw, when I was coagulating it, the entire vessel, if you go and get one go, somewhere one edge remains open, and once you start flowing, then you're lost. Okay. So tiny vessels are okay. So I ensure you say your diathermy is clean. You ensure that is really working, and you have temperature is very high. Once you go all out, just puncture whole thing off there. That's what you look at it. You gave a chance, you start using, and directly angioma is size, looking at it and very high flow. I will not be able to coagulate entire thing. That's the reason even when they do laser, the TTT try about whether, like, depending on size, whether you want 2 or 3 millimeter size of lesion, and then but that's a cooking, that's a slow cooking sort of thing. That's a different than direct diathermy coagulation, because I wanted to dissect it with a straight with a diathermy, not coagulation, and then use a cutter to cut, because I'm not sure whether eventually whether whole thing is closed and coagulated. So if I use a cutter, maybe somewhere I would have left behind part of it, and you start using, then it's become messy.
If time permits, can I show a little half minute?
Vinod, we have very short time for another heroic surgery.
I just make a quick
Hemant
comment
sir,
there.
last comment.
Yeah. Generally, most of these angiomas have multiple feeder vessels. So it's always, it always has this greater tendency to bleed. So it's very tough to know which feeder, where it is coming from. So a lot of these have multiple feeder vessels, generally never one.
Yeah, I have right now a patient with 3 feeder vessel. We did the PDT for him. All right, let's move on with a next hero and heroic surgery. Anirudh, thanks PV sir for fantastic case and discussion.
Thank you so much. Thank you.
Anirudh, go ahead.
Very good evening. Thank you to AIOS for this opportunity. Thank you, Jay. Confirm if you can see my screen.
Yes.
Is my screen visible?
Yes, please. Go ahead.
Can you see my screen, sir? Can you confirm, please?
Yes, we can see. Anirudh, can you hear us?
Anirudh, can you hear us?
For some reason, I'm not able to hear the panelists. So, Jay sir, if you can just write on the chat box if you can see the screen and hear the audio, please.
We can hear you.
Thank you. So at the outset, I'd like to thank also my wife, who's also a vitreoretina specialist, Kanika, for helping me give the narration for the video. And I'll just go ahead with this case. It's a lady who came to us, and I'll start with the video and probably we'll have the discussion at the end.
This is a story of an incredible journey of hope that took us from darkness to light. Our patient was a 50-year-old lady brought to our clinic by her neighbors. She had no vision in the left eye since childhood and had now developed vision loss in right eye over the past 3 months. She had no caregivers and was now totally dependent on her neighbors for activities of daily living. She had never been systemically evaluated. Given her monoocular status, it was imperative to do something, and do something fast. Standard 3-port pars plana vitrectomy was initiated. We can appreciate scleral thinning nasally. We knew right away we would need a phacofragmentome to tackle the rock-hard nucleus. But even a phacofragmentome was no match to the tenacity of the nucleus. Finally, we could overcome the devil. Now lay ahead the Herculean task of tackling the retina, which looked nothing more than a crumpled piece of paper. After switching to bimanual dissection using mini light source, we made further headway by injecting PFCL and started to unravel the delicate retina tethered precariously to the optic disc. The membranes were firmly adherent to the retinal surface. At one point, attempts to remove a tenacious membrane in the superior retina led to retinal rotation and a catastrophic risk of a large retinal tear or even disinsertion from the optic disc. It was like walking a tightrope. But we managed to hang on. So, it was important to go very gentle and preserve maximum retinal integrity. Finally, the seemingly impossible retina unfolded completely. At last, the eye comes back to life. A 360-degree endolaser was performed under PFCL. Lastly, PFCL oil exchange was done. Seeing the patient walk independently at 3 months made all the nerve-wracking and heart-wrenching moments that we just witnessed absolutely worth it.
It's the one and only Eagle Double G.
Okay, so I
Fantastic.
think that I'll just stop, and I'd love to hear the comments from.
Fantastic. Great job.
Great case. You see, honestly, I would know. I have operated 360 GRTs, but I
I'm
think
sorry,
this
I'm
was-
not able to hear.
Yeah. So I will put in the chat box that this was one of the toughest case. Honestly, I would, if the other eye was good, I would not have operated this case.
I think Darius has shown a similar video a couple of years back.
Yeah, but any thoughts on because one of the challenge which we all face in this type of cases is the rotation.
Yeah.
Means obviously you don't worry too much that okay, at least the patient should get vision. But how do you
Yeah.
actually prevent rotation if it is already 360-degree torn apart? Any thoughts or comments on that, Dr. Giridhar?
I don't know. I mean, basically, I think our aim is only to fix the retina, right?
Mm-hmm. Yeah.
I think good job is because the first thing is he always, because now of course you have a good instrument, but the bimanual surgery, what is decided to start with, because when the retina is so mobile and having a subretinal membrane also, I think excellent thing is just he started with the bimanual. Generally quite sometimes these eyes, there's hardly any vitreous. Only thing is just membrane. And you ensure that you have mobilized the retina well. And what you need is like a very slowly you start injecting PFCL. Periodically look at where your fovea is, macula is rotating. And probably you have to bring back, and probably when you go beyond the macular area and arcade is flattened, you look at it again, macular position. And suppose you feel is rotated away from, from the desired location, either you are back flush or gently cutter suction, you hold one edge of the GRT, tug little bit, try to bring it back. Because the early stage, if you do that, it will rotate back it because it is sort of a stretched and contracted retina. Once you start feeling, as keep on adding and keep on simultaneously drag the edge back to ensure that fovea is in place, and then it holds on.
Absolutely, very nice.
But I think this being one-eyed, even if a bit of rotation is present, I think it should not matter.
Agree.
Yeah.
Yeah, I mean,
Patients you may not.
We have learned
excellent job actually. He has done excellent job.
I'm sorry, I couldn't hear. I'm back again.
Yeah,
excellent job.
We were just praising you.
We are just praising you.
You didn't miss much.
You see, Anirudh, what I said was that if it other eye was okay, I wouldn't have touched this.
Yes, she was one-eyed. So and the most difficult part for me was she came to me when I just joined as faculty, and this was my first year of my position here, so it was very difficult for me.
It immediately made you a mature surgeon.
Okay. Any other comments, or else if we do
No,
have a
so
few minutes.
I
Yeah.
think when we start peeling the membranes and at least one quadrant, we are basically onto that. So I may put a diathermy mark at 6 o'clock so that we know how much rotation and
Oh,
what is happening.
Yeah.
that's a great tip.
Good idea.
That's a great tip. And any thoughts on exchanging PFO with oil, or somebody would still go ahead and try PFO gas exchange and then put oil?
I always
PFO.
do
PFO
direct.
oil.
I always do PFO oil.
Oil.
Okay,
I think the
I think it's an
Alexandra.
individual perception. The way each one of us train, I think we take a call accordingly. Once retina is flattened down and laser is done, I think it's just the way we are trained. I think we take a call accordingly. I think either way is okay as long as you're confident with handling that step.
Yeah.
I think the
Alexandra, any
bimanual
thoughts?
by Constellation, the bimanual gives you very good control with direct PFO oil exchange. I think that's very useful.
Yeah, I wanted to hear something from Alexandra. Any thoughts, Alexandra?
I think it's a gorgeous case. I love the production too.
And he played really safe by thanking his wife too.
Yeah, exactly. It was very well done. I love the last slide as well. So, but I think it's a challenging case, and I just want to say, in a lot of these case presentations, it's giving a chance to a patient is important. Obviously you want to have a good pre-op counseling because sometimes patients expect things that we can't always deliver. But complex trauma cases like this, if you can try and give an option, and sometimes we're lucky and the retina cooperates. So beautifully done.
Thank you.
Nice. I do have a couple of questions from the session from audience. So I'll just try to answer as many as we can. We have only 7-8 minutes left. So the first question is for Dr. Murthy about his ILM peeling in high myopes. Do you want to share any specific comments while peeling the ILM in high myopes, and how do you deal with the instruments? Many a times they don't reach to the macula.
Yeah, so I just look at it preoperatively to decide whether I should do it without the PFCL, depending on whether there is this. If there's a dome-shaped macula, I feel I could reach the ILM. I would do it directly. I go from the disc to the periphery, so I would be able to peel the ILM. But in a lot of patients, we do have to do it under PFCL, wherein I stain it under the PFCL and then peel the ILM. Now, the only problem is the challenge is because of the length that we need. So I do use a 26 gauge 1.5 inch needle to first give me the flap, so that then I can peel it, because holding it is a problem because the retina is extremely thin. So you try to hold it, you will produce a bleed, then you lose that. So each time you try doing it, you'll always have a lot of these problems. So I try to do that, or you could use a Finis loop. I use a 23 gauge wired one port, the active port, and I use 25 gauge instruments because then there is no leakage. It becomes very stable.
Yeah, and something more means which I particularly use it, that always start the ILM in a detached retina. It's safer to start from nasal to temporal. So you use the optic nerve as the lever and try to pull it from nasal to temporal. So that makes the job a little simpler. There is one more tricky question. I know that I had this comment last week when I was dealing with one COVID-associated endophthalmitis. Is that do we blame COVID for endophthalmitis or the immunosuppression? Because COVID has been blamed for every possible thing, even for hair loss. Yeah, Taras, do you want to make any comments?
Is a virus and is a clearly fungal endophthalmitis. You can't really blame it directly, but definitely
the immunosuppression.
It is the reason, the immunosuppression. We are trying to study some of these cases, and what we found interesting is that even the studies published in NEJM, etc., recommend 10 days of steroids or lesser for these cases. But somehow in the Indian subcontinent, the amount of steroids given to our patients, we studied a few cases, was more than 32 days. And this gentleman got more than 50 days of steroids. So I don't know whether there's some, we are really using too much of steroids, and whether that needs to be highlighted to our physician friends. Of course, steroids are life-saving, so we don't want to send a wrong message that don't use steroids, but everything should be used judiciously. So I think that's one thing which we may need to discuss with our physician friends if we see more of these cases. And Dr. Raja also said an alarming number of cases he's seen from LV Prasad.
So in our series, 21 out of those 24 patients had received steroids, either intravenous methylprednisolone or oral steroids.
Are these patients diabetics and having multiple other comorbidities? I mean,
our cases didn't have much comorbidity. So I think Dr. Raja's cases were having more comorbidities, but ours were generally well controlled. Diabetics and hypertensive, few of them. This gentleman was well controlled, but that is the alarming part, is whether this duration of steroid being so prolonged is, and the free access to drugs which our patients have, some of them self-medicate, etc., whether that is causing more of this problem. I don't know.
Right. Gopal?
Yeah, so I just wanted to say that it is not just the steroids. These patients will be in the ICU. They will have a lot of central cannulations. They will have catheterizations, and a lot of not so trained in the ICU doctors may be looking at them, and the sterile techniques may be breached here and there. The sugars may not be really well controlled when all these are there. So there's a lot of chance where there is a bacteremia or a fungemia occurring and causing a.
Right. Hemant sir?
Yeah, that was, I think, the point is that it has to come from some source. It's immunosuppressed, but the problem is they generally put central lines, which are very common. I find that central lines are the common place for all these infections to occur.
And that's an important point, because this person told me that the IV line had got highly infected during the course of his hospital stay, because I took a detailed history. So probably they may have, if they grow the IV line, there may be candidemia on the tip of the IV line or something. So I think that's a good thing to look into.
True, definitely. All right, I think we are towards the end of the symposium. Thank you so much. I think we had a fantastic variety of cases from VHL to endophthalmitis. Thank you so much. Thanks everyone for sharing your experience.
Thank you, AIOS, for this opportunity. Really wonderful session. Learn a lot, actually. Learn a lot. Thank you so much for having me.
Thank you for this opportunity, and I think thanks everyone.
Great job.
Great learning.
Thank you so much. All right. Have a great day.
Bye-bye. Bye-bye.
Have a nice day, nice weekend. Enjoy.
Bye.
Bye-bye.
Bye.
Thank you.